Welcome, everyone. My name is Anita Pfeffer, and the title of my PhD thesis is Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy, and Adherence. I have been working at the Pediatric Center Tűzoltó 3 department for 3 years, and now I'm a first-year PhD student. My vision is to improve the survival and life quality of oncological patients, and my mission is to identify the least harmful and most effective therapeutical opportunities for oncological patients. Here you can see my 2 ongoing projects. In my first project, I would like to investigate the effectiveness and safety of available therapies in adrenocortical carcinoma, and in my second project, I would like to focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivals. Now let me introduce my first project, titled Comparing the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma. We are planning to do a systematic review and meta-analysis in this topic. Shortly about the background. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available, especially in childhood and in advanced stages. My aim is to evaluate the effectiveness and safety of additional therapeutical modalities. But why is it important? 4 different stages of adrenocortical carcinoma can be distinguished according to the severity of the disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical modality contributes to recurrence-free survival and overall survival. My clinical question is, which one therapeutic modality provides the best survival and lowest number of side effects? I use the PICO framework, in which population will be patients with adrenocortical carcinoma, intervention, additional adjuvant therapy, the comparison, no additional adjuvant therapy, and the outcomes, mortality, and side effects. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increased survival rate in adrenocortical carcinoma. I conducted a systematic search in the middle of November, and I found more than 17,000 hits. After the selection process, I have 83 eligible full texts, 2 of them are RCTs, and the others are retrospective cohort studies. Here you can see my most important outcomes. I would like to investigate the overall survival and recurrence-free survival based on the different treatment approaches of adrenocortical carcinoma. And now I would like to show you my first results. On this forest plot, we investigated the effect of additional mitotan treatment on overall survival in pediatric and adult patients with adrenocortical carcinoma. Overall survival is the length of time from either the date of diagnosis or the start of a treatment for a disease such as cancer. This is one of the hardest outcomes to see how well a treatment works. We investigated the overall survival about 750 patients in the intervention and about 1,000 patients in the control group. We included 30 retrospective cohort studies in our analysis, and we divided them into 3 different subgroups based on the stage of the disease. We investigated separately the overall survival in patients with stage 1-4, in patients with stage 1-3, and in patients with recurrent disease. The importance of this subgroup analysis is that the effectiveness of the treatment can be highly influenced by the extent of the disease. The I-squared number is 68, meaning the level of heterogeneity is statistically high. It can be caused by the heterogeneous population of the included studies. The measure of effect is the hazard ratio. If the hazard ratio is more than 1, so it is on the right side of the level of no effects, it indicates that the intervention group has a shorter survival compared to the control group. If the hazard ratio is less than 1, so it is on the left side of the level of no effects, it means that the intervention, so in that case, additional mitotan treatment reduces the risk of mortality. The overall hazard ratio is 0.6, which means that additional mitotan treatment reduces death by 40%. This result is clinically relevant and statistically significant. We got the same results based on the subgroup analysis, and we found that additional mitotan treatment reduces death in patients with localized and advanced diseases as well, and these results are clinically relevant and statistically significant. On my second forest plot, we compared the overall survival in patients who received additional mitotan treatment with those who did not receive it. The most important difference compared to the previous forest plot is that we have put adjusted hazard ratios here. Adjustments were made according to the columns you can see on this forest plot. We got the same results compared to the previous one, and the overall survival was even better. And now let me show you this regression plot, which shows that the more variables are adjusted for, the smaller the value of hazard ratio is, which supports our previous results. The most important strengths of our analysis are the stage-based subgroup analysis, the high number of participants, and the complex and comprehensive analysis. To highlight limitations, most of the included studies were non-randomized studies. There is a high heterogeneity of patients' characteristics, and there are missing adjustments for important variables in some studies. In conclusion, we can say, according to mitotan treatment, that it has significant therapeutic benefits in localized and advanced stages in patients with adrenocortical carcinoma. The clinical implication of our finding is that clinicians should suggest starting mitotan treatment after surgery for the affected patients. For further researches, we recommend organizing randomized controlled trials to minimize the selection bias, and more studies are needed to evaluate the effect of the different additional therapies in the pediatric population with adrenocortical carcinoma. Here you can see the progress of my first project. I received about 5% of my forest plots, and I wrote the methods part of my manuscript. And now let me tell you some details about my second project, titled Efficacy and Safety of Growth Hormone Therapy for Pediatric Brain Tumor Survivals based on real-world data, and we are planning to do an international survey in this topic. Brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. However, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common is growth hormone deficiency, which can be caused by the hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed international guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency in the clinical practice and investigate the effect of the different treatment approaches for safety and efficacy. My clinical question is, how does the different management of growth hormone replacement influence the growth and the risk of recurrences and secondary malignancies in pediatric brain tumor survivals? I would like to use the PICO framework, in which population will be pediatric brain tumor survivals, intervention and comparison, the different management of growth hormone replacement, the primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement according to the international guidelines provides best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. The clinical implication is for patients improved quality of life, for clinicians optimizing growth hormone therapy, and for policymakers maximize the potential clinical improvement. To summarize, as I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the least harmful and most effective therapeutical opportunities for them. With these two researches, I would like to contribute to achieving this. My favorite quote is from Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your attention.
Congratulations on your presentation. It was really nice, and I would like to ask about your first topic. What is the recommendation of the radiotherapy in adrenocarcinoma? Yeah, so yes, you can see.
Thank you for your question. Based on the current guidelines, radiotherapy should be suggested just based on individual way, especially for those patients who has high risk of recurrence, such as patients with stage 3 disease or positive surgical margin, etc., or for those patients in whom the primary surgery is not manageable.
Congrats on your excellent presentation. I would have a question about your second topic. You mentioned that there are guidelines for growth hormone replacement, but that clinicians are not following those. What do you think? Why is that?
Thank you for your question. Since growth hormone is known to have a mitogenic effect, there is a theoretical risk that its use may increase the risk of recurrences and secondary malignancies. And although the majority of literature data show that growth hormone replacement is not associated with higher incidence of recurrences, its use may increase the risk of secondary malignancies. And it can cause fear for clinicians to start growth hormone replacement as early as it should be. And if they start it in normal time, then they usually use smaller dosages than they should.
Congrats, brilliant presentation. So I had a question for the first project. So based on the results, do you suggest to start the treatment with mitotain from the first stage, considering also the risk for adverse events?
Thank you for your question. I would suggest in those cases when the surgical resection is not manageable totally. So when, for example, the patient has positive surgical margin or a higher risk for recurrence in patients with stage 1. But for example, for patients with stage 2 or stage 3 disease, yes, I would suggest it.
My question would be, if I remember correctly, you in the method you analyzed pediatric and adult population together. What was the reason for that?
Thank you for your question. As I mentioned earlier, adrenocortical carcinoma is a very rare disease. The incidence is 1-2 per 1 million people in the adult population and just 0.2-0.3 per 1 million in the pediatric population. Based on the rarity of the disease and the lack of data, the children are treated based on the similar protocols as the adults, and unfortunately we didn't have enough data to investigate separately the different treatment approaches in the pediatric population.